Pneumonia. Today we will read about pneumonia. Definition. Pneumonia is an inflammation of the lung parenchyma that is caused by a microbial agent. Pneumonitis is a more general term that describes an inflammatory process in the lung tissue that may predispose a patient to or place a patient at risk for microbial invasion. An infection in the lungs caused by microbes leads to inflammation that brings water into the lungs. It makes it difficult to breathe. During inhalation, air enters into the trachea and continue to the bronchi, bronchioles and to the alveoli. The air exchange happens and reach the bloodstream where CO2 reaches the bloodstream, and when we exhale it goes out. A normal protection in our body, when we inhale air, microbes together will enter an intact host defense mechanism, and mechanical factors like coughing and other one mucus ciliary escalator all over the airway passage removes the larger microbes. Macrophages destroy the microbes and some escape and colonize in the bronchioles and in alveoli. Causes pneumonia. Pneumonia causing microbes: bacteria, virus, that is influenza, flu, mycobacteria, chlamydia, mycoplasma, fungi and parasites. Pneumonia has been categorized into one of four categories: bacterial or typical, atypical, anaerobic or cavitary. Fourth one is opportunities. The other classification scheme categorizes the major pneumonia as community acquired pneumonia, hospital acquired pneumonia, otherwise called nosocomial pneumonia, pneumonia in the immunocompromised host, aspiration pneumonia. These classifications are because they may occur in different settings. Mycoplasma pneumonia, Chlamydophila pneumonia, Legionella pneumonia. In these three, no cell wall present and it causes atypical or walking pneumonia because often causes symptom, that is fatigue. Community acquired pneumonia occurs either in the community setting or within the first 48 hours of hospitalization or institutionalization. The need for hospitalization of community acquired pneumonia depends on the severity of pneumonia. The agents that most frequently causes community acquired pneumonia are people who live in the crowded areas, close contact with pathogens or mycoplasma and chlamydia, influenza. Legionella also causes, but it is from the water source. Streptococcal pneumonia, Haemophilus influenza, Legionella, Pseudomonas aeruginosa and other gram-negative rods. The chief causes of viral pneumonia is the immunocompetent adult or influenza virus types A and B, adenovirus, parainfluenza virus, coronavirus, varicella zoster virus. Cytomegalovirus followed by herpes simplex virus, adenovirus, respiratory syncytial virus, and viruses are the most common cause of pneumonia in infants and children, but are relatively uncommon causes of community acquired pneumonia in adults. The acute stage of viral respiratory infection within the ciliated cells of the airways. This is followed by infiltration of the tracheobronchial tree. With pneumonia, the inflammatory process extends into the alveolar area, resulting in edema and exudation. Hospital acquired pneumonia, also known as nosocomial pneumonia, defined as the onset of pneumonia symptoms more than 48 hours after admission to the hospital. 15% to 20% occurs with the patients who are admitted in ICU. Ventilator associated pneumonia can be considered a type of nosocomial pneumonia that is associated with endotracheal intubation and mechanical ventilation. The most common organism responsible of hospital-acquired pneumonia include the pathogens Enterobacter species, Escherichia coli, Klebsiella species, Proteus, Serratia marcescens, Pseudomonas aeruginosa, MRSA, methicillin-resistant Staphylococcus aureus. These respiratory infections occur when at least one or three conditions exist. That is, host defense are impaired, inoculum of organisms reaches the patient's lower respiratory tract and overwhelms the host defenses. Third one, highly virulent organism is present. Impaired host defense includes severe acute or chronic illness, a variety of comorbid conditions like coma, malnutrition, prolonged hospitalization, hypotension, metabolic disorders. The hospitalized patients are exposed to potential bacteria from other sources. Example, respiratory therapy devices and equipments, transmission of pathogens by the hands of healthcare personnel. Aspiration pneumonia. Oropharyngeal secretions, gastric secretions get into the airway when cough reflex and gag reflex weakened and decreasing swallowing reflex. The central nervous system disease, stroke, seizures, Parkinsonism, central nervous system depression, alcoholism, sedation, and in intubated patients, these cough, gag, swallowing reflexes are diminished. Aspiration of gastric secretions causes the Klebsiella, Staphylococcus aureus, anaerobic infections leading to pneumonia. Pathophysiology. Upper airway characteristics normally prevent potentially infectious particles from reaching the normally sterile lower respiratory tract. Thus, patients with pneumonia caused by infectious agents often have an acute or chronic underlying disease that impairs host defenses. Pneumonia arises from normally present flora in a patient whose resistance has been altered, or it results from aspiration of flora present in the oropharynx. It may also result from bloodborne organisms that enter the pulmonary circulation and are trapped in the pulmonary capillary bed, becoming a potential source of pneumonia. Usually our body will prevent the organisms by coughing, and the cilia will remove, and our gag reflex all will remove the potential organisms. But some escapes and it goes into the lung, and the underlying causes also predispose the infection, inflammation, and causes pneumonia. Pneumonia often affects both ventilation and diffusion. An inflammatory reaction can occur in the alveoli, producing an exudate that interferes with diffusion of oxygen and carbon dioxide. White blood cells, mostly neutrophils, also migrate into the alveoli and fill the normally air-containing spaces. Areas of the lung are not adequately ventilated because of secretion and mucosal edema that cause partial occlusion of the bronchi or alveoli. With a resultant decrease in alveolar oxygen tension, bronchospasm may also occur in patients with reactive airway disease. Because of hypoventilation, a ventilation perfusion mismatch occurs in the affected area of the lung. Venous blood entering the pulmonary circulation passes through the underventilated area and exits to the left side of the heart poorly oxygenated. The mixing of oxygenated and unoxygenated or poorly oxygenated blood eventually results in arterial hypoxemia. If a substantial portion of one or more lobes is involved, the disease is referred to as lobar pneumonia. The term bronchopneumonia is used to describe pneumonia that is distributed in a patchy fashion, having originated in one or more localized areas within the bronchi and extending to the adjacent surrounding lung parenchyma. Bronchopneumonia is more common than lobar pneumonia. Clinical manifestations. Pneumonia varies in its signs and symptoms depending on the organism and the patient's underlying disease. Patients with streptococcal pneumococcal pneumonia usually have a sudden onset of shaking chills, rapidly rising fever 38.5 degrees Celsius to 40.5 degrees Celsius, pleuritic chest pain aggravated by deep breathing and coughing. If patient is severely ill with marked tachypnea 26 to 46 breaths per minute accompanied by signs of respiratory distress, shortness of breath and use of accessory muscles in respiration, the pulse rapid bounding increases 10 beats per minute for every degree of temperature elevation. A relative bradycardia for the amount of fever may suggest viral infection, mycoplasma infection or infection with Legionella aeruginosa. The onset of symptoms of pneumonia is gradual and non-specific. Some patients exhibit an upper respiratory tract infection, nasal congestion, sore throat. The predominant symptoms may be headache, low-grade fever, pleuritic pain, myalgia, rash, pharyngitis. After few days, mucoid or mucopurulent sputum is expectorated. In severe pneumonia, the cheeks are flushed and the lips and nail beds demonstrate central cyanosis, a late sign of poor oxygenation, hypoxemia. The patient has orthopnea, shortness of breath when reclining. He or she prefers to be propped up bed leaning forward, orthopenic position, trying to achieve adequate gas exchange without coughing or breathing deeply. Signs and symptoms of pneumonia may also depend on underlying conditions such as cancer or in those who are undergoing treatment with immunosuppressants which lower the resistance to infection. Such patients have fever, crackles and physical findings that include consolidation of lung tissue, including increased tactile fremitus, that is vocal vibration detected on palpation. Tactile fremitus, TACTILE, tactile fremitus, FREMITUS, tactile fremitus, that is vocal vibration detected on palpation. Percussion dullness, bronchial breath sounds, echophony. When auscultated, the spoken E becomes a loud nasal sounding A, and whispered pectoriligui. Whispered sounds are easily auscultated through the chest wall. Pectoral oci, PECTORILOQUY, pectoral oci. Purulent sputum or slight changes in respiratory symptoms may be the only sign of pneumonia in patients with COPD. Assessment and diagnostic findings. The diagnosis of pneumonia is made by history, physical examination, chest X-ray. That one shows patchy areas of consolidation occur in bronchopneumonia. The entire lobe is consolidated in lobar pneumonia. Blood cultures. 2 times it will be done before starting antibiotics. And sputum culture. Medical management. Administration of antibiotics as determined by the result of Gram-Stein. Treatment according to existing illness and risk factors and according specific pathogens. Antibiotics are ineffective in viral upper respiratory infections and pneumonia. Antibiotics are indicated with a viral respiratory infection only when a secondary bacterial pneumonia, bronchitis or sinusitis is present. Hydration is the necessary part of therapy because fever and tachypnea may result in insensible fluid loss. Antipyretics may be used to treat headache and fever. Antitussive medications may be used for the associated cough. Warm, moist inhalations are helpful in relieving bronchial irritation. Antihistamines may provide benefit with reduced sneezing and rhinorrhea. Nasal decongestants may also be used to treat symptoms and improve sleep. Also keep in mind that excessive use of may cause rebound nasal congestion. Treatment of viral pneumonia, with the exception of antimicrobial therapy, is the same as the bacterial pneumonia because antimicrobial therapy is ineffective in viral pneumonia. Complete bed rest is needed until infection shows signs of clearing. If hypoxemia develops, oxygen is administered. Pulse oximetry and arterial blood gas analysis is performed to determine the need for oxygen and to evaluate the effectiveness of therapy. A high concentration of oxygen is contraindicated in patients with COPD because it may worsen alveolar ventilation by decreasing the patient's ventilatory drive, leading to further respiratory decompensation. Respiratory support measures include high oxygen concentrations, endotracheal intubation, and mechanical ventilation. Supportive treatment includes hydration with caution and frequent assessment because of the risk of fluid overload in the elderly. IV chart should be maintained. Supplemental oxygen therapy, chest physiotherapy with deep breathing and coughing, and frequent position changes and early ambulation. To reduce or present serious complication of pneumonia in the elderly, vaccination against pneumococcal and influenza infection is recommended. Complications. Severe complications of pneumonia include hypotension, shock, and respiratory failure, especially with gram-negative bacterial disease in elderly patients. Atelectasis and pleural effusion. Atelectasis from obstruction of the bronchus by accumulated secretions may occur of any stage of the acute pneumonia. Parapneumonic pleural effusions occur in at least 40% of bacterial pneumonias. And empyema occur when thick purulent fluid accumulates within the pleural space. And the last one, superinfection. Superinfection may occur with the administration of very large doses of antibiotics. In such cases, bacteria may become resistant to the antibiotic therapy. That's all. Bye.